Good afternoon. My name is Linda Protopapis. I'm the Executive Vice President of Sales for HealthRecon Connect. Good morning, good afternoon to our three-part series, What's Next for COVID Labs? Today, we're going to be talking about PGX. Next Wednesday, November 2nd, will be UTI, wound, nail, STIs, infectious disease. And then part 3 of the following Wednesday, November 9th, will be RPP and GIP, infectious disease. To walk you through this, it's our honor to introduce you to our Director of Laboratory Services Support at HealthRecon Connect, Mr. William Baus. A little background on William. He has over 15 years experience in healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle management, building onshore and offshore and hybrid teams to satisfy the needs of his clients. William has worked inside laboratories as the internal revenue cycle director with preview over every step of the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through the adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs. A few reminders for the attendees. If you would like to ask a question, you may do so by sharing your questions via the chat box or raising your hand. Upon that, I will enable your audio. Following the conclusion of the webinar, please take a few minutes of your time to fill out the short survey. Let us know what you liked about the webinar, how we can improve, and what other topics you would be interested in for future webinars. As a reminder, the recording of this webinar will be published in all of our social media pages in 2 to 3 weeks. Please do keep an eye out for that and for that post, and share the link with your colleagues who couldn't make it today and those you may find content covered during this webinar useful. I will also be sending out a copy of this recording via email to all of the attendees. And with that, William, it's all yours.
Great. Well, thank you for taking the time to join us today. We'll be talking about PGX. And so as always, you want to make sure that whenever you're, actually, I meant that slide to be there. Whenever you're going to take any of the information we discuss in today's call, make sure that you run it by the relevant people that are, your coding organization, your compliance, your legal, your clinical operations, wherein they interact or intersect with the topics that we talk about today. Everybody could have a slightly different situation or variation, or even be in a different state could make a difference for you. So don't just run with this. Make sure you talk to an expert before you apply any of the information. So today we're going to go over a few topics, some base ones that you may all be very familiar with. So I'm going to go quickly through them so we get to the meat of it. But what's a MAC? Why do you care about it? What's a Z code? Why do you care about it? What is PGX? Then we're going to talk about the common factors for PGX reimbursement across all the MACs. Then we're going to talk about what happens in a non-MolDX MAC, already kind of previewing why it's important to know what a MAC is. And then we're going to talk about some of the commercial payer policies, and then expected reimbursement for Medicare, and then expected reimbursement commercially speaking. So let's get started. So what's a MAC and why do I care? So for the purposes of this discussion, we're predominantly going to separate them into 2 categories. You've got your MolDX MACs, which are Palmetto, Noridian, WPS, and CGS. So this is all of Noridian over here in the blue and the pink. Then you've got WPS over here in the, let's call it yellow, and some green over here. And then you've got Palmetto in the hotter pink and the, I don't know, let's call that lime green. And then, of course, you've got the really blue here, light blue for CGS. Those are the 4 MACs that you have to, well, your MAC is participating in the MolDX exchange program. And so you're going to need Z codes for any molecular diagnostic testing. And we're going to take a look at, well, what are those codes and all of that. Then your non-MolDX MACs are, of course, Novitas over here in the blue, as well as, I'm going to go with MAUVE over here in Pennsylvania and those little states right next to there. And then you also have, of course, First Coast, which is Florida, Virgin Islands, and Puerto Rico. And then you have NGS, which is over here to the west of the Great Lakes, as well as New York and pretty much anything north of New York. I think one interesting thing to note is Novitas and First Coast as a MAC are pretty much in lockstep with exactly word for word verbatim LCDs, and they usually drop it on exactly the same day. NGS, another non-MolDX MAC, is quite separate and has, in this instance with PGX, a very different policy. In fact, no specific policy on PGX, rather just a molecular policy, and we'll take a look at that a little bit today as well. All right, so let's move on now that we know what a MAC is. So those MolDX MACs that I just mentioned, those 4 of them, they use the MolDX program. I think it's also important to notice that the Medicare Advantage plans are now utilizing the MolDX program. This is really important because originally the way that it was released, the first one to really release it was United Healthcare. And United Healthcare actually originally said it would just be in the MolDX MACs, but they have released something that I want to show you sometime back. Linda and everybody, if you guys can't see this, tell me. You should be seeing a different PDF right now. So in April, the requirement to use Z codes was expanded to include all the states. Now, I did just notice a first denial, and I thought it was a mistaken denial. So we were going to go off and appeal it, but now I'm going to go back and say, yeah, I think we're going to have a problem because they're going to say you need that Z code. I have had denials where people have billed PGX without a Z code. In CGS, for example, it had happened, and we just needed to put and since they already had Z codes, it was just a matter of, oh, we just need to put the Z codes on and resubmit and get it paid. But this is likely to be that case for all of the Medicare Advantage programs. So getting a Z code and understanding what the MolDX program is probably something that would be good for anybody that's going to also be billing Medicare Advantage plans, and that's a lot of us. So yay. Now, what's important to note as well is they've released what codes they're dealing with in waves. And so we're on wave 9 now, and it's still in, not to get too technical with you, but all the codes we use in laboratories start with an 8, and then there's another digit after that that usually classifies it into a particular section. And so most of the codes they're talking about are in the 8.1, and I'm going to show you a list here in a second. Let me fast forward a little bit over here. All right, so these in general are the codes that you need to be thinking about that you're going to need a MolDX Z code for, particularly if you're going to be billing a Medicare Advantage, or you know what, even if your lab is not in a MolDX MAC, but let's say you want to be a reference lab for somebody where you're going to run the sample, but they're going to bill it. Well, they would need your Z code if they happen to have to bill to a MAC that's in a MolDX MAC, right? So it might be a good idea to start thinking about getting Z codes. And it's a very stringent technical assessment kind of model that you have to deal with. So it's good to get familiar with that. So you've got your MoPath tier 1s, molecular path tier 2s. You got all the GSP codes. You got your unlisted codes that kind of go with these categories. Like this one's a multi-analyte algorithmic analysis code, which kind of pops up a lot. And this one, and here are all the MAA codes. And of course, if you had a proprietary laboratory analysis code, well, yeah, you'd need to get a Z code for that too. You'll know what those are because you made them and it took you 2 years to do it. Or you're using some FDA approved test and not an LDT, and they'll tell you to use their code. What was recently added and what most people would be hearing or talking about right now are the syndromic panels, those infectious disease panels like nail, wound, UTI, GIP, RPP, all of those. Yeah, you need to get a Z code for those too. And those start with 8.7. So as you kind of notice, everything kind of starts with an 8.1 or it's an 8.7 right now. What they've released for the Medicare Advantage programs, though, are just the 81,000 series. So far, you're okay on infectious disease for the Medicare Advantage plans. And again, to be specific, what I am talking about is Medicare Advantage plans. So Medicare Advantage United, Medicare Advantage Aetna, right? Those are those plans, not Aetna itself, not United itself, okay? Now, as far as commercial payers or other payers besides Medicare and Medicare Advantage plans, the only other plans that I'm aware of at the moment that utilize the MolDX program would be Medical Mutual of Ohio, Fallon Health, and Blue Cross Blue Shield of North Carolina. So not commercial payers in general, and well, except for those three, and two of those I think are HMOs. All right. So the next thing is, okay, well, great. Now you tell me I need to get a Z code. What is the Z code? Okay, so you can refer to it as a MolDX Z code. Sometimes I just call it a Z code, not to be confused with the diagnostic codes that start with Z, which are also called Z codes. This is a special code that was created by McKesson in 2011. They had the prescience at that time to realize our CPT code set was woefully inadequate in describing what we do as laboratories. And so they said, you know what? We can fix that problem by making people tell us a whole bunch of information that we classify, and then we give them a code so that when that code is attached to a CPT code, we know actually what they did. And that might have a change or an impact on reimbursement. And in general, one could say for most molecular pathology, you would typically see less reimbursement in a MolDX state. And that'll be because you kind of get reduced to using one CPT code. You don't have the ability to express what you did in multiple CPT codes the way that you traditionally could in a non-MolDX MAC. But we also have LCDs in place to kind of curb that a little bit as well, which will be a little bit outside the scope of this conversation. But of course, you can always contact us and we can have a good talk about your panels. Okay, so DEX Z code is a unique 5-character alphanumeric code identifier for a laboratory test. It is actually considered somewhat private. Like if you go on the DEX exchange and start looking stuff up, you can't just find somebody's DEX Z code. You'd have to register yourself and then request it from the lab, and then they give it to you. So to get a DEX Z code, well, you fill out about 36 fields of information, and hopefully y'all can see this. This over here on the right-hand side, this is what a Z code card comes back when you get a Z code, what it looks like. You know, it'll have your name of your test up at the top, and then it'll have your name over here. You tell them whether or not you're the performing lab, and they know what jurisdiction you're in. You put in all of your molecular analytes and components. This happens to actually be a UTI, for example, which, by the way, nobody has actually gotten their own Z code for a UTI nail or a wound, or basically anything. Even the ones that exist in the billing coding are they've never even gotten yet, except for LabCorp Quest, which apparently got, you know, some STIs. And of course, no worry about PGX. I was talking about infectious disease. That's what people are really talking about now. So it does matter what kind of testing you're talking about and the difficulty of getting a Z code. You have different technical assessments and this sort of thing. You can definitely get a Z code for PGX. Do not be afraid. Just get in there and go do it. And we've helped our clients do it in the past. We can help you do it too. All right. So what happens when you get a Z code is your Z code will be over here under your DEX Z code. And then what usually confuses people a little bit is the CPT codes here that say current. Those are the CPT codes you asked for when you said you wanted a Z code. Those are typically not the CPT codes you will get when you're doing a bunch of things together to get one Z code. There's a bit of a trick about that for pharmacogenomics. And if you want that trick, you're going to have to call us to get it, but I can help you kind of figure out how to make sure you actually get the right CPT code for your PGX. So in this instance, what they were given was an 87999, which is an unlisted code, which has no fee schedule associated to it. And then you recognize what you're looking for is when you first get your Z code back, these will be blank. They're going to start to work on your technical assessment. When they've got a good overview of what you're doing and they're pretty sure that there are no existing codes for it, they're going to give you some unlisted code probably, unless you're doing it right. And then before you can bill it, you'll notice that it has to say it's covered. And when it is covered, you will have a MolDX price for whatever this unlisted code is. Unless, of course, you figured out how to actually use the CPT codes that exist and actually have a fee schedule already associated to it, then you are good to go. And that's what you can do when you're doing PGX if you do it right. And so everything that you see here are the kinds of questions that they ask you for your Z code. So what the first thing is that you do to do that is you go to over here on the left-hand side. So you'll notice it says Palmetto. This is something that usually confuses people as well. While Palmetto is a Medicare administrative contractor in its own right, the parent company of Palmetto is called Palmetto GBA, and it owns a bunch of other stuff. One of the things it owns is the Diagnostics Exchange and the MolDX program. And you need to go here and register on that site. And then there's some buttons you click on that get you to the form on the right where you kind of fill in everything out. And then after that, within about 2 weeks, they come back and give you the Z code. And they say, okay, you got 15 days to complete your technical assessment, which is a spreadsheet. There's different ones for different kinds of testing. So like for syndromic panels, there's a different technical assessment group of forms for that. For PGX, it has its own specialized form for that. And you fill that out. And usually within about 15 days, they get back to you. If you've done something wrong, they'll say, hey, this is what you did wrong. If you want to fix it and resubmit it, please do so. And then, you just keep going through that until you get it done. Let's make sure I didn't miss anything. Yeah, so these are the steps, right? Your Z code, get in about 2 weeks, then you do your TA. Once your TA is approved, you're going to get your MolDX recommended CPT code and your price, then you bill. Don't be billing before all that stuff is done, or problems can happen for you. People are actually doing that right now in the syndromic panel stuff. That's a little bit out of scope for today. But if you don't have a Z code and you need a Z code, then you're looking at potentially clawbacks, right? Okay, so let's move on. So we went over those already. Good. Okay, so I'm sure everybody here has a pretty good idea of what PGX is, but I thought, hey, we should at least address the elephant in the room there, right? So what you're doing is you're looking at people's DNA and you're identifying the variants called alleles, and you are trying to figure out how to, either somebody needs a bigger dose or a smaller dose, or they shouldn't even take the drug. And so that's what we're looking for, whether it's Medicare or commercials. They want medical necessity, and medical necessity is broken down on a gene by gene basis with a combination of a medication that is actually got results that when you get these results, you're going to know whether you should do selection avoidance or dosage changes. And we're going to get into that in a little bit more detail. But so basically, how does somebody metabolize a drug? That's what we're looking for. And it's not just any drug, and it's not just any gene. There's only certain genes that are at the right level of clinical evidence that Medicare and commercial payers will feel confident that this information is actionable and will help change the treatment of a patient. All right. So there are 3 factors in common with PGX for pretty much everybody, right? The 4th factor is needing an ICD-10 and a non-MolDX MAC. So let's address these 3 things, and we're going to take a look at them in a little bit more detail. So the first thing is you got to be testing a gene that they believe has a gene-drug interaction with a medication. So there are certain genes that people test and have traditionally tested in the past that are not considered at the right level. So we're going to fast forward a second, come back here in a minute. So first things first, Medicare is not making that decision up by themselves. They are utilizing the FDA or CPIC. And, why don't we take a good look at the actual CPIC? So you kind of get a sense of what's here, and you'll understand, I think, a lot more about it. So this is CPIC. It has to be level A or B actionable use. Okay, so HLA-B in combination with, I'm going to go with abacavir. That's a pretty cool name, abacavir. If this gene is being studied and it's in relationship to this drug and it's level A, that means CPIC is saying there is actionable use for interrogating that gene for those alleles for your patient if they are taking that medication, or the doctor is considering the prescription of that medication. And so you can kind of get an idea. There's a lot of genes in here, but notice they're kind of being repeated sometimes because the gene always has to be in combination with a med. It's not just, oh, I tested the gene, I'm going to get paid for it. That's not how it works no more. You got to have the gene, and you got to have the med being prescribed to the patient or being considered for prescription to the patient, and I need in documentation that the doctor is saying, I'm doing this for selection, avoidance, or dosage. So like if you're already prescribing, maybe I'm looking at deprescribing. Okay, great. Or maybe if I'm considering for prescription, maybe I want to know selection or avoidance. And then if it is that I'm going to select it, maybe I'm going to want to know information about dosage. But I've got to indicate, yep, I am prescribing or I am considering prescribing this med for selection or avoidance or dosage or all three of them. Okay. And so we've got quite a long list. You can see it goes all the way down. You know, B is still okay. And we start falling out at BC, right? Now, what's interesting is there are genes in here that are not in the Medicare list, right? And so we're going to look at that in a quick second, but let me get back to the overview. All right, so that's the thing about genes. It either needs to be CPIC level A or B, or it needs to be FDA with therapeutic management recommendations. And sometimes they even put it on the label that you're supposed to get tested before, but that's only on like a few meds. So it's either one or the other. And a lot of times there's a lot of crossover, but there's a few that are just FDA only, and there's a few that are just CPIC only. So it does make sense to pay attention to both of those. But truly, you really just want to pay attention to whatever Medicare's got on their list. If that's what they're going to pay you for, you're going to spend a lot of time arguing about stuff that they're not even going to understand. And in the non-MolDX Max, you've got a bigger problem as well, which we'll get into. All right. So we got it straight with the genes, and I think we're going to have it straight with the meds, and we're going to look at that in a quick second. But I want to talk for another quick second on ICD-10s. Now, in no way at all am I implying that you don't need diagnostic codes for the MolDX Max. You do. But it's not the same as it is for, say, Novitas and First Coast. And that's because for each gene, there's also a group of required diagnostic codes for which you must have one of. If you do not have that diagnostic code, then you do not have medical necessity according to that LCD. Now, in a MolDX Mac, this is actually, I believe, an advantage for you. One of the very few tests you could ever do in a MolDX Max and have an advantage, it would be PGX. Now, why? Well, because your doctor doesn't have to figure out how to pick the right diagnostic code for the right gene when you're not even asking them to pick the gene anymore and just pick a med, which is going to be kind of a nightmare. But there is a solution to that. We can help you out with figuring out how to put your requisitions together. But it does just add another hurdle to getting a medically necessary order on a piece of paper that somebody can go, yep, that was medically necessary. Okay. And then the third thing that's in common is the provider qualifications. There'll be a slide in here later that I get very specific with on it. But in general, the person ordering the PGX test should be the person that is prescribing the medication for the patient or managing the medication for the patient. So probably not going to expect to see a cardiologist ordering antidepressants for his patient, unless she happens to be managing the medications about depression for that patient, which then you'd be okay. So it's supposed to be, or has to be, the person who is managing the medications. And then there's some other very specific things, like they have to be trained and skilled and qualified to have diagnosed the patient and to prescribe the drug and all that kind of stuff. So, but I mean, that would be who's managing the medication, just to keep it short and sweet, right? All right, so FDA, CPIC, we did that. Oh, I didn't want to go there. And let's go here. All right, so there is variation in the max, and we're going to talk about that. And then non-MolDX Max, First Coast, and Novitas and Sync, we kind of addressed that. National Government Services is interesting in that they don't have a specific PGX LCD, and we're going to look at that. And then DX code requirements for non-MolDX Max complicate the ordering. We just touched on that. All right, so let's have a peek at some of these policies. All right, so just as a quick update, I'm going to be looking at the billing and coding articles. Billing and coding articles are now paired with the LCD. In the past, they used to kind of mush all that together. So your LCD is usually just a bunch of words that describe their philosophy on stuff. And then the billing and coding article is where the rubber hits the road for a biller or talking about reimbursement, because that's where they're going to say, oh yeah, if you want to like bill that code, well, you better have one of these diagnostic codes, or you better not have one of these diagnostic codes, or, you know, we don't even pay for that CPT code. They'll say all that stuff in the billing and coding article. So this is where you really want to go. So first thing I wanted to touch on is a way to read one of these LCDs is you always open up the contractor information. Make sure you're looking at the right contractor. So CGS, Kentucky, Ohio, they're a MolDX MAC. Okay, you're going to see that all the MolDX MACs are pretty much in alignment. So the table that they're going to have about the genes and the drugs that they're going to pay for are going to be listed in here. And the important thing is, this is as of November, or excuse me, March 26th of 2021. And for the FDA, it says of November 8th, 2021. So they're almost like a year behind. So if you do happen to go directly to CPIC, you're probably going to pick up on some things that are there, but not actually in the LCD. And well, that's probably going to cause you problems for billing, even more so for a Novitas or First Coast. This is because you have the additional requirement of having a diagnostic code. So if you come up with your own gene and they don't have a diagnostic code group for it, then if they pay you or they don't pay you, they can always come back later and say, well, you didn't have the right diagnostic code. And then it was also because they didn't tell you which one was the right one, right? Okay, so for the most part, I'm just going to flip through these really quickly just to kind of show you whatever region you're in. If you're a MolDX MAC, they're going to be talking about the same time frame. Here it is again, it's the same time frame, and this is going to be Palmetto. You know, see, that's the same time frame. And then we've got, what is this? That's Noridian, and so they're using the same time frame and the same kind of table setup. And then this is going to be Novitas or First Coast, because the table looks a little different. That's Novitas, and Novitas is as of March 29th, 2022. So they're a little bit more updated in terms of which genes they're on, but you can kind of see that the table split up a little differently. And it doesn't really matter that, you know, the difference is they're telling you it's generic name, trade name, and then they have intended uses for the drug. These guys put intended uses for the drug and the drug classes and the generic name all in one group. It really doesn't matter. Since this table is a little simpler to look at, we're just going to look at this one for a quick second so I can show you the relationships. So on the left-hand side are all the genes that they pay for. Those are the genes that you will get paid for. If you did COMT, or if you did MTHFR, MITFR, whatever that one is, right, which is in a lot of people's panels, you can still run them. They're just not going to get paid, right? Now, Factor 2 and Factor 5 for certain select Medicare administrative contractors is a paid-for gene, but not under the PGX policy. It's related to a biomarkers policy for thrombolism, and you'll get paid for those, although it's not the same test that you would be running, because you would be running a PGX version of that test, which, as far as PGX is concerned, they are non-covered. They are not related to any meds that matter or that are believed to be graded by the FDA or CPIC as having therapeutic benefit to do. So what they're expecting to be paying you for when they pay for that gene is a different test altogether. All right, that being said, what do we need to do here? Well, if you are in a non-MolDX MAC like Novitas or First Coast, and we'll talk about NGS separately, you first, everybody needs to have a med from the patient, right? And that med needs to be selected by the doctor as saying, I'm either prescribing that med or I am considering the prescription of that med for my patient. And they need to also indicate why. And the why is greatly simple, just straightforward. I'm doing it because I'm thinking about selecting it. I'm doing it because I'm thinking about avoiding it or deprescribing it. I am selecting this med in this test because I'm trying to figure out the dosage for my patient, right? Selection, avoidance, dosage, that's it. So they say, yep, my patient's on that drug. They need to say, I'm doing that because I want to select, avoid, or figure out the dosage. Okay, great. If you're in a MolDX MAC, you're done. You already done it. You're done. That's all they need to do on their order form. If you are in a non-MolDX MAC, you have to jump through an additional hoop. And that additional hoop is contained in this article. And you'd have to say, okay, 81225 is in group 2, and it is, and we'll go see that in a second. Let's do that. Find it. Where is it going? Okay. Find group 2, or no, 81225. So we got a bunch of 81225s. And oh, they're in group 1 codes, excuse me. Who's that? I'm sorry, I'm actually looking at a MolDX Mac. I'm looking at Noridian. I'm sorry, I need to be looking at First Coast or Noridian. No, or there we go. I must have clicked on it incorrectly. Oh, it's switching me around. That's crazy. All right, we'll just scroll down. All right, so see, group 2 is 81225, and then I need to find group 2 for the diagnostic codes. And down in group 2 is a list of a bunch of diagnostic codes that I need to have when I'm billing an 81225. So if I don't have one of these 67 diagnostic codes, then I don't have medical necessity as far as First Coast or Novitas is concerned, which is, well, problematic, because now how do I get the doctor to know which group to work on and all of that? And so you can talk to us and we can help you work through the Y4s and whatnots of that. There's a couple of different ways you could go at solving that problem, but you do need one of these diagnostic codes or you don't have medical necessity according to your LCD if you're in Novitas or First Coast. If you were in any of the 4 molecular diagnostic MACs, WPS, Noridian, CGS, and Palmetto, I would have been done as soon as my doctor said what med he was prescribing or considering prescribing, and he told me selection, avoidance, or dosage. I'm done. I've even built my medical necessity into my order form. And if I ever get even asked for documentation, I've got everything I need on my requisition. I mean, amazing. So this is probably one of the best well thought out LCDs that Medicare has ever come up with. I'm like really proud of them. Let's give them a clap. They should do more of that, right? So now let's look back at what we got next going on. Okay, so we did that. So we did the updates in the times and the syncing, MolDX, no specific PGX policy. Oh yeah, I needed to show you. There is kind of a little bit of a problem with NGS. And this is what their policy looks like. So they actually just have a policy about molecular pathology procedures, which it contains, among other things, PGX, but a lot of other things are in here. And what's very interesting to me about their attitude is very similar to the way commercial payers write their policy. And I'll show you a more condensed version of me going through a bunch of different payer policies. Commercially speaking, to kind of give you a better sense of this, right? But they talked about, the black box warning. So there's like 3 or 4 meds that they'll talk about. They'll talk about Plavix that they're willing to pay for. They'll talk about Oligostat, tetrabenazine, and like that's pretty much it. And then they don't mention a whole bunch of other CPT codes. So I'm quite sure you do get paid well from NGS. I don't have a lot of clients in the NGS MAC that I'm familiar with right now and looked at their data sets, but I'm pretty sure you're going to get paid as well as we do from commercials. And you'll see why I'm saying that, because they'll put things in their policy about what they won't pay for. And then they kind of tell you in general, they really don't like the CPY thing and they think it's experimental investigational, but they don't explicitly say a whole bunch of other stuff that they don't pay for. And so it kind of leaves things a little wide open. And the way that if you read the policy, you kind of think at first, oh, they're not going to pay for anything. But I've got data to show you today, but they are paying. So that's kind of this is what their policy is. You'd have to look and go, okay, I'm doing CYP 2T6. And if I was doing, oh my God, I can't remember how to pronounce this one, but the word that's highlighted there, if you were doing that one, they'd be cool with it, right? But they're kind of not telling you that they would pay for, like, there's 10 other drugs that they could be paying for, but they're not telling you whether they do or whether they don't, or what your medical necessity is, or if you need a diagnostic code, or if you need a certain kind of ordering provider requirement. They don't say anything. So NGS is kind of like, I don't know, 20 years behind the times in terms of figuring out PGX, right? Okay, let's see here. Let's go back to that. All right, let's move on. Let's see, good, we're doing right on time. All right, so let's talk about a valid billable event. And I think we've kind of discussed and described it a little bit, but I'm going to just really break it down straightforward to you. You have to have a medication with a gene drug interaction that's already prescribed or being considered for prescription, as according to the CPIC and the FDA at the right level for the gene. Okay. And then the test results must directly impact the drug management on the patient. Of course they do. I mean, like, why else would we be doing the test, right? But here's the point. What is that said succinctly? Well, it's selection, avoidance, and dosage. That's it. All right. And then the last one is kind of what we already talked about as well. It must be ordered by the treating clinician that is responsible for the pharmacologic management of the patient's condition and must have the licensure, qualifications, and necessary experience and training to both diagnose the condition being treated and to prescribe the medications. So like a medical director at a nursing home, maybe, right? Yeah. So whoever's managing the meds for the patient is who should be, trying to get this information so they can select, avoid, or dose change the patient, right? That seems pretty straightforward, but you'd be surprised, right? I mean, you really should not expect somebody who's a heart surgeon or what do you call them? A cardiologist trying to prescribe psych meds for a patient, right? That doesn't make a lot of sense. So gone are the days of, oh, I have a psych panel and I have a cardio panel and I have a pain panel. Those days are gone, at least from a reimbursement perspective. I mean, you can put them down on your requisition that way, but they don't make sense anymore. What makes sense is, are you on the med or not? And am I going to select, avoid, or dose change it or not? Now, if it makes it easier to group them as menus like that, that's everybody's choice, but it's irrelevant from a payment perspective. All right. Commercial payer policy. We're going to take a quick look at this stuff. So in general, they'll all say they pay for three things. And even the Medicaids will say this too. They're going to say things like, we pay, if you have Huntington's disease and Gaucher's disease, we'll pay for tetrabenazine at greater than 50 milligrams, or we'll pay for Eligostat. And then Plavix, heck, you don't even need a diagnostic code. We'll pay for the Plavix, no worries. But what's actually happening in reality is a little different. They're obviously paying for more than just what they said they would pay for. So there's stuff that they're paying for that they haven't really defined a policy about, is what I'm getting at. Now, my recommendation, though, is this. They always kind of refer, everybody knows that everybody's going to copy Medicare when it suits them, and maybe not copy Medicare when it doesn't suit them. But if you will read through the policies, a lot of time they make some kind of a comment that says, it's got to be medically necessary and you got to have a standard body saying something about it. Well, if you follow what you're doing for Medicare with commercial payers, and maybe their policy isn't explicit about whether they should have paid you or not, and maybe you're worried about a clawback, well, here's what you do to kind of protect yourself on that. If we're following the Medicare rules that I'm only picking a med, that's CPIC or the FDA, my God, who's going to contradict the FDA? I hope not the CMS, right? But if they did say, hey, we don't think that was medically necessary, I think we could have a really good, strong argument with somebody to say, well, it was on the FDA black box warning. I mean, I don't know what else you want to know about that. And I'm going to show you a commercial policy that literally says something very similar. But when you actually look at the list of tests that they say they don't pay for, it's every test that I've ever seen. But I can also show you data that shows me getting paid. So I think if we follow the Medicare guidelines in this instance, we're going to be safe on multiple levels. We're going to be safe with Medicare Advantage plans. We're going to be safe with Medicare. We're going to be safe with Medicaids. We're going to be safe with commercials. All right. That being said, let's look at some of those commercial policies there. Well, first I want to show you. Here is Cigna's policy. I just want to show it to you online before I show it to you that I've kind of mushed a bunch of them together in a spreadsheet, right? So this is pharmacogenomic testing for non-cancer indications. Because there are a lot of oncogenes that make sense for testing for onco drugs, right? But for our normal kind of thought of PGX, this is what they're saying. So the individual is a candidate for targeted drug therapy associated with a specific gene biomarker or gene mutation. Check, we've got that, right? Because they're either being prescribed or being considered for prescription for a drug, right? Yes, and it happens to be a drug that has a drug interaction. If we're using Medicare's rules, then we're meeting that right there, right? The results of the test will directly impact clinical decision-making. Okay, selection, avoidance, or dosage. Boom, 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 we got them. All right, now the testing method is considered to be scientifically valid to identify the specific gene biomarker or gene mutation. Well, if you know how to do an LDT and you passed your LDT, and if you got past a technical assessment from a MolDX MAC, boom, you got it. Now, and then it's either of the following, and you're going to have either one of these. Indication of the specific gene or biomarker for use with a specific drug target has been demonstrated to improve clinical outcomes for the individual's conditions being addressed. Well, if you're using a gene and a drug that is listed as A or B on the CPIC, guess what? Boom, you just met that one. And the other one is the FDA. And at first they used to say black box on, or no, indications and usage, which that one's a little bit hard because it's not the same as saying FDA therapeutic recommendations. But certainly if you were talking about one that's on the actual label of the bottle of the pill telling you need to take it, well, then you would be meeting that requirement. But remember, it said either or. And, as long as I've got CPIC or the FDA with therapeutic drug recommendations to me, then I'm meeting that first requirement. So what's interesting then is they spend another 20 pages telling you all the reasons they don't want to pay you for PGX. And then you can actually, there's a genetic testing collateral file. If you look at that, it tells you every gene panel that's in there is non-covered. And the reason they said that was because you were trying to bill 25 genes every time for every patient. You don't do that. You only bill the genes that you have a med for that are CPIC or FDA level, and you're going to be fine, right? So this is a classic example of these guys being so clever. I mean, they do their job very well to figure out how not to pay us. And they writ it in such a way that you think you're not going to get paid. And we're going to take a look at that in a second. And I just wanted to kind of give you a smattering of what all of these other commercial payer policies kind of look like. Then, so for Cigna, I broke it down and put that in there. And then they're telling you in other parts of the document, they actually pull out genes and they say they don't cover them. But I actually have payment for those genes from Cigna. Medicare Advantage is just going to follow Medicare. UHC commercial. Okay, there is one special thing about UHC that I would say we would want to do a little bit differently. One of their things that they're very specific about is you already have to have prescribed the patient, and you would have had to have had a negative interaction or a negative reaction to the drug. Then they'll pay for your whole damn panel, right? No more than 15 genes, but okay, that's still a lot of money from United Healthcare, right? And they were very specific that they wanted to pay for, the psych side of things, the SSRIs, the tricyclics, the antidepressants, and they want F codes, right? But on top of that, and United is the stickler that always wants to do everything the Medicare way. And these are the guys who started all this stuff about Medicare Advantage is going to make you use Z codes because we follow Medicare rules. Well, I'm going to shove Medicare rules down their throat until they pay me. So that's what we're going to do with United. Now, Humana, kind of similar to what we saw with NGS's kind of policy, very similar to Blue Cross Blue Shield. You'll see Alligastat, you'll see tetrabenazine, and these are $600 codes, by the way, by themselves. So, I mean, they're nothing to snub your nose at. But it's funny, they're yeah, they're going to tell you that they want to cover those. And then they literally tell you all these other ones are considered not medically necessary in their policy. But I got good payment from Humana too. So we're following the Medicare rules. We're going to get paid. Aetna, a little bit more specific on some of the stuff they will pay for, a couple of extra things. There's Alligastat, tetrabenazine, they've got Plavix, and then there's, I don't know how to pronounce that one, fluoxetine or whatever. And actually that one's a not covered one. And it's rando how they do this. Sometimes they'll say, oh, it is covered or it's not covered, but they don't tell you everything that's not covered and they don't tell you everything that is covered. And I think they're just doing that to mess with us, right? And then BCBS, this one happens to be an Anthem. And Anthem, I think, is managed by AIM or somebody. So all the Anthems would look similar in all their policies, right? It's Plavix, Alligastat, tetrabenazine, that they say it, and then they don't say what they don't pay for a lot, although they kind of tell you in general they think it's not medically necessary. Yeah, so All right, that's the commercial payer policies. Let's see. Okay, so yay, we're getting into the expected reimbursement. Again, it's really driven by the number of meds. And if you're in First Coast or Novitas, you're going to need your DX codes. And so, your CPTs are going to range between $80 and $500. If I look at the $10 million we've collected for our clients, that's going to average out to like $300 per CPT. I mean, I don't know how relevant that is. It just depends on the meds. Okay. So I tried to give you a couple of examples. A psych patient being prescribed Zoloft or being considered for prescription is going to hit on 2 genes with 1 diagnostic code. You're going to make $740. It's like 741 or something like that, right? Let's say it was a cardiologist patient and they're being prescribed Plavix. That's going to be $291. And I mean, this is like if that was the only med they had. Now, if they get a couple of other meds, you're going to be adding in, on average, another $300, right? Now, you upgrade yourself to a nursing home where you've got a medical director that's got purview of, a patient and their polypharmacy, 25 meds they're on. Well, now you're talking $1,500, $1,800, right? And then I thought, why not show you a really basic one that surely everybody has taken an NSAID before. And that's $174. There's 70 million prescriptions of NSAIDs a year in America. So yeah, I think just about everybody should have a PGX test. Now, $174 by itself probably isn't a good enough reason to run a test, at least from a reimbursement perspective. But I think most people, if they're on Zoloft, they're probably also taking NSAIDs too, right? So you just added another $174. Now, when we talk about commercial reimbursement, and I limited the data set to basically since about a year ago, about a year's worth of data. That's been about $10 million collected for our clients, 500 plus payers. When you're out of network, you're looking at plus or minus 20% of Medicare for an allowable. But don't forget you got deductibles, right? And that 10 million I'm talking about that's the actual money collected, not the bill charges. When you're in network, you pretty much get close to a Medicare allowable, at least in the context of PGX. What you're looking at per CPT in terms of payment, $55 to $450. It's like $50 less is what I was saying, but the average comes out about the same. Zoloft would be more like $650, Plavix would be more like $260, polypharmacy would be more like $1,000. The NSAID would be more like $160. So you're kind of like right on the money. That's money in the bank. You're going to have some that goes, 100% to deductible, but you've got the right to ask for some of that money too. You don't have to send people to collections, and you're required to make a good faith effort to collect anyways. You might as well actually get something when you do it. And that concludes my presentation, and that leaves plenty of time for questions. So do we have any questions, Linda?
Currently, we do not. Does anyone have any questions at all for William?
All right. A question that does come up for me a lot is, so how do I make a requisition? And I think I touched on it a little bit. If I was in a non-MolDX MAC, or excuse me, if I'm in a MolDX MAC, I think really the only thing I would want to see on there is a med. And then I'd want to know whether it's being prescribed, or if it's currently being prescribed, or if it's being considered for prescription. And then I would want to know selection, avoidance, or dosage. And I guess there's lots of different ways you could come up with compiling that, but I'm just thinking of a list of meds with different columns that you can put little check marks under that are under those kind of selections. And now what you've done is you've built in your medical necessity for the order, because you're not even really going to see those kind of Well, I doubt that in his notes or her notes that she will have written down all the details that she would need to tell you that I am currently or not currently prescribing it, and then I want to know this information because I'm thinking about deprescribing, or I'm thinking about selection, or I'm trying to figure out dosage for my patient, right? For every one of the drugs that there's going to be, that would be highly unlikely that that's just going to exist in their notes somewhere, right? So you're going to probably want them to have that on your requisition. So when we inevitably do get asked for documentation, you've got something to show that, right?
Hey, William.
Yes,
I do have a couple of folks. So I'm going to allow Diego Sanchez raised his hand.
Sure.
Diego, can you hear us? Would you like to ask William your question, sir?
Yes. Thank you.
You're welcome.
Thank you, William. Yeah, I just wanted to confirm the information about, so you guys recommend to build PGX for on commercial payers following the CMS guidelines?
And yes, unless I've got something specific contradicting me, like in the context of United Healthcare, they want you to have already prescribed and have had an adverse reaction. But Medicare doesn't care, right? Medicare is like, hey, if you're prescribing it or you're thinking about prescribing it, I'm okay with that. So, you know, in that context, I think there's a conflict, and I would do what United was saying to make sure I met their medical necessity. Yeah. And there are some variations with different payers. I mean, but for the most part, they're being very specific about 3 things that they will pay for, and then they're specific about a couple of things they don't pay for, and then they're kind of not saying anything about a lot of stuff, which kind of leaves everything all up in the air. And if everything's going to be up in the air, I want my fallback to be, I did a gene that I've got plenty of material, peer-reviewed literature, clinical trials and studies that have been going on for over a decade to support me in the medical necessity battle that I might have to have with a payer. I'm going to want to fall back on Medicare's guidelines, which really aren't their own guidelines. I'm really falling back on the CPIC and the FDA, right?
Got it. Okay, thank you.
Sure.
And William, we have one more question from an anonymous attendee. Can a pharmacist order a PGX test?
Pharmacists are not considered physicians by Medicare. So as a standalone pharmacist, I believe the answer to that is no. Although this is not 100% my expertise, and there is a margin of error here, but I'm pretty sure I'm right. But there is an out that I am aware of for a pharmacist. There is the concept that a pharmacist can bill incident to an MD. I believe this is actually going on because the concept of medication therapy management, which is sometimes covered by various payers, I believe it's called MTM, or something like that. And the concept is pharmacists want to be able to spend the time to manage the medication therapy for a patient, you know, and look for adverse drug interactions, which, by the way, PGX does not look for drug-on-drug adverse drug interactions, by the way, which a pharmacist would. And I am seeing PharmD overrides on the PGX testing now as well, looking for exactly that kind of thing. So it does make a lot of sense. I think what you need to do as a pharmacist is hook up with an MD and bill incident to them. So then you have access to the E&M level of service, where, you know, it's basically based on the amount of time that you spend with a patient. And under their license, you are able to bill. You're going to need to talk to a lawyer about that and make sure it's right. And there, you know, it may be variation in different states about who qualifies to actually bill incident to a physician. But I'm aware that that is what has occurred in the past in various states for pharmacists if they wanted to actually have access to the physician fee schedule for billing something. But no, in general, my understanding is for you to order a test, you have to be a physician. Oh, and then I do know that there are state-based scope of practice rules about that as well. So there could be, like, everything might be okay, except your scope of practice in your state restricts you from doing it. So you definitely want to talk to a lawyer in your state about that. Yeah.
And I also have a I'm gonna link in Nikita. She has a question for you.
Great.
Yeah, it's actually him. But hey, William, how you doing?
Good, man. How are you?
Good, good. Hey, so as far as commercial billing is concerned, we have a larger panel that we run, and part of that panel, there are genes that we analyze that would be technically billed under tier 2 CPT codes. Do you advise against billing the tier 2s?
It's very interesting you say that. Let me show you something. I believe, and we would have to talk about each gene and look closely at it for it. But notice this down here. Medicare's telling you to do that. What is it? 81406 or something in here. Yeah, it's for what are these things? These are the anesthetics, right? This RYR1 and then Carnacus. So they give you 81406, and then a lot of these codes are giving us an 81479, which is going to just make billing nastily confusing because it's stupid. I mean, they tell us to use that 81479 one code for everything too, and it's like now they're telling us to use it for the individual genes. But yeah, I mean, the precedent for using a tier 2 code, Medicare itself is saying to use it in their own LCD. And Medicare is very contradictory about things like, last year, the du jour problem was, oh, you're not using the right modifier. It can't be 59 anymore. It's got to be XU. Well, now all my dang policies say 59 all the time, right? So they contradict themselves quite a bit. But given what you're actually looking at, and if we do fit and meet the definition of the code, I think it would be appropriate. I would just be really super careful if you thought, for example, like the old days, that you were going to bill an 81408, which is $2,000 for
No.
8. Yeah, no, probably not, because you're not looking. Because you got to look at the other part. 81408 was for 50 exons or greater, right?
Yeah.
I mean,
Well, it's whole gene it's full gene sequencing, which you're not going to do full gene sequencing for PGX.
Right, right. And I think 81406 is still talking about SNPs or something, right? But
yeah, which falls in line if you're doing NGS, which is what we're doing.
oh, okay. That was one thing. That's a big hole in my presentation. I didn't mention NGS testing of the PGX. Well, in general, the PGX, the CPT codes, unlike say some of the infectious disease codes that explicitly identify.
And this is, sorry to interrupt, by the way, we're billing out of the Novitas Mac. I see that you have MolDX pulled up here.
Yeah. Well, it's the same in, let's see, I think this one's Novitas. Yeah, this one's got to be Novitas because it's got the diagnostic codes. It'll be there too. It's pretty much all the genes are the same, even though I was mentioning that there is some kind of variation in here. Well, here, let me just search for it. Oh man, I don't understand why it's showing up over there. Find. Yeah, see, it's there too. And they're slightly different, like Carnacus, I don't know what CACNA1S, it wasn't in the same order in the other one, but they're all, I mean, I think there's 2 or 3 genes that are a little bit different between the two because they're about a year apart of each other in terms of when they took it from CPIC, right? But yeah, you're fine. I mean, in the NGS concept, your codes are not restricting you to a methodology in the same manner that, well, like the COVID CPT codes explicitly identifying it needed to be PCR, and then you might have to pick amplified or direct or quantified probe or something like that. So yeah, we could definitely use the same CPT code set. It's not really any different than what you're going to be doing on PCR anyways. You're going to run all of those genes every time on PCR. Just make sure you only want to try to bill for what you have the medical necessity for. And if you're in Novitas, that you also have to get your diagnostic code too. And there's actually a way for us to be compliant with the problem that you're going to be presented with. Like any lawyer would tell you, what is ordered must match what is resulted, must match what is billed. And there appears to be a conflict with that, but there's an easy solution to that problem, to be in compliance with this section here, where it's not appropriate to bill Medicare for services that are not covered as they have told you throughout that whole LCD, when billing for non-covered services, make sure you use the appropriate modifier.
Right.
So, yeah, yeah.
Got it. Thank you.
You got it. Awesome.
Any other questions for William? All right, William. Well, that concludes our webinar for today. Again, I will be sending out an email. It will have William and I, both of our contact information, along with the link for this webinar. Please let me know if you'd like to set up any additional Zoom meetings. We'd be more than glad to do that. And with that, thank you all so very much for attending today's webinar. Again, next week, Wednesday, we have another, as part of our 3-part series, it'll be UTI wound, nail, STIs, and infectious disease. And then November 9th, we'll close off our series with RPP, GIP, and infectious disease. With that, thank you so much and have a great day.